volunteers and NGO workers and lawyers working with migrants, but not so much social workers. I hope that will change in both countries. And as you mentioned in the presentations, one important thing to change is that include culture awareness, culture sensitivity in training. I think that's an important thing so that future social workers could be more aware of the issues of migrants and can identify migrants, can work with migrants. They have the ability, the competence to do that. So I think in a sense that there's a lot to do in education, social work education, I think. However, and that's me keeping it brief, one thing I realized that Sri Lanka, when compared to Japan, and you guys, Sri Lankan social workers, you have a huge advantage, an inherent strength that we do not have in Japan, is that while you're not always aware of it in your practice, regardless of social work, Sri Lankan society itself is already historically and traditionally a multicultural society. It's also multi-ethnic, multi-linguistic, and very importantly, multi-religious society. So what I mean by that, why that is a strength, because Japan is one of the most secular countries in the world. So it's difficult for us because sometimes we do not consider ourselves so much spiritual or religious. So it's difficult to be aware of the importance of spirituality in other people. And many migrants, of course, are not that secular as Japanese people. So I think that it's a huge strength what you have. And I think, you know, many of you mentioned that since your own faith is important for you, being it Buddhism, being it Islam, being it Christianity, or also Hinduism, since you understand how your own faith is important for you, it's easier to understand and have the motivation to learn about other people's spirituality, which is, I think, the most important thing in working cross-culturally, because all the values come from spirituality, come from religion, and all those values represent themselves in how people live, lifestyles, customs. So I think that's very important. So I was especially impressed by I think it was one of the students that she mentioned that herself is Catholic, but she's reading the Quran. I think that's really something that that you can be proud of. I think I just wish that we were so eager in Japan.
හරිනේ.
So and the last thing I would is that it's very well. So yes, and since you already have that, regardless of professional education, you already have a sense of spirituality and a sense of having a strong heritage in your own case. You are aware of. You are maybe even unconsciously aware of in your everyday life that Sri Lankan society is multicultural. So I would suggest that there's also a lot of work to do to record that hidden knowledge that you already have, that know-how. So I think many people already do it on an everyday basis. So you just have to look at it, how that affects social work practice, and how it can be, related to theory, and how it can be taught in schools of social work. Until all starts, actually, I was really impressed that one last message I would like to emphasize from the presentations is actually, I think it's the presentation just behind that one. You started with cultural sensitivity, and cultural sensitivity starts actually with a motivation to know, to being genuinely interested and show genuine interest. So it's not about being, competent, so to say, in another culture, but to be able to work with the client, to learn about his or her culture on your own, and you have to have a genuine interest in people to do that. But I think that's what we as social workers are good at. Thank you. That will be all.
So with that note, we have come to the end of the first session of today's program. So thank you very much, Dr. Victor Burak, for your insightful presentation. And now I would like to invite Mr. Nalin Dhammika to give away the token of appreciation for our speaker.
So the challenge we face is probably it's nothing new. We are having a situation which is evolving. It is changing. And over the past few years, things have changed a lot. And there is an increasing need for care, for comprehensive care, health, social, those aspects. And there is a decrease in the provision of care due to lack of resources and so many things, economic crisis, migration, and so on. And if you look at the illness part, I'm focusing on that because we have for 20, 30 years, we have been looking after the poorest of the poor in the hospitals. And the sort of social support they need is enormous. So next I would like to talk about the elements of a crisis and how we are going to respond to this crisis. So the evolving situation is given here, and then the balance between increase in need for care and the fact that we are having a decrease in capacity. So there is an increase in need and a decrease in capacity. You have heard of all this. The aging population in Sri Lanka proportion-wise, therefore the increase in chronic diseases and the recurrent acute infections and acute exacerbations we have. So that's one, the increasing need for care. And on the other side, you have a decrease in capacity because the care which is provided by the state sector is in hospitals and clinics. We have a very good preventive health sector, the MOH system, for maternal and child health. But when it comes to curative care, we have a deficit. So we have less resources and we are having a fall in the number of carers. That's where migration comes in. There is an exodus of qualified health workers, there is an exodus of carers, there is a large number of young people are going and leaving the elderly people here. They are going to look after the elderly overseas by leaving their parents to be looked after by someone else. That's the irony, right? And families are shrinking. My parents had 7, 8 brothers and sisters. I have one. My children have one. Right? So families are becoming what we call nuclear. So there's migration, families are changing, there is female employment. And females who are caring for families and members of the family are now gaining employment in factories or as domestic workers or going overseas. So you can see that we are heading for a crisis in care. Health, social, psychological, moral, we are heading for a major crisis. And when it comes to the health sector, of course, we are looking at the illnesses. And there are unreached populations. We were discussing about that yesterday. The chronically ill are not covered properly by social care. We give a few handouts, but otherwise it's not comprehensively covered. You can have an accident and break your spine, and you might get a few thousand rupees. You can get a stroke, and there isn't care in the community. No one is coming for physiotherapy. No one is coming from the state to feed you. You can be 90 years demented and living at home. There's no one helping you if you're alone, other than the neighbors and the family. So we are having, in the health sector, if you look at the health sector, we are having a major crisis which we have to face. And the next two slides is based on our work which we have done. Because we have been sending our students to the community for past 20-30 years. It was started by Professor Sharif. So when a person is very ill, we say gets a stroke, the students visit those families, and some of the families are living in places like that in Colombo. And when they visit those places, it's transformative. Because you must remember, some of these children who become doctors and nurses have never stepped into a poor person's home. Some of them now, in our generation, we walked, we went by bus, we have slept on the floor, we've done everything. But now you get a generation who have never gone in a bus, have never gone to a market, never spoken to a poor person, never stepped into these areas. So it's transformative and it changes. And when we look at it, these are the sort of problems the students have identified. Now this is important because this is where social workers come in. This is where social workers come in. We are giving you information from the ground, 20 years experience. These are the problems faced by people who are ill, who have been discharged from hospital, stroke, heart attacks, whatever. And when they go, they have to face their medical problems, they have physical problems, they can't walk sometimes. They can't access health care. Some of them are on the 4th floor of a flat given by the government and there's no lift. So you rely on someone else for the medicines. Personal habits, drug dependency, smoking, alcohol, mental health issues, lack of recreation. You're trapped in some of these small households. Living arrangements, people sleep on relay in small houses. Some people sleep at a particular part of the night and the next batch takes over because there's not enough room. Food is scarce. Housing, there's overcrowding. Common toilets are being used by some. Of course, now majority are having toilets. Majority have some sort of electricity. But during the crisis, now with the increase in prices, the poorest of the poor are losing their electricity because the government is disconnecting exchange. Social aspects, loss of employment, and when you lose employment, there is nothing in the state. Give a few thousand rupees, right? You don't have any social support in that sense. As a result of the crisis or illness, children will stop going to school because they have to look after the parents or to get employment. There is loss of connections with your neighbors, with your families. Luckily, the mobile phone helps, but social networks get disrupted, and there's discrimination, especially in mental health. She will tell you the details of how people are discriminated, stigmatized with a mental illness, especially with a mental illness. And of course, we have hazards, issues of safety, waste collecting in those environments, floods and so on. So these are some of the issues the students identified. And these are some of the things which, if you are really having a comprehensive social worker network, you can help. So then I focused on illness. This is based on a paper I wrote because the illness, even though our health system is supposedly free, there are costs. There are direct costs still. Sometimes the drugs are not available. Now much better, but some of the drugs are not available on time. Some of the tests cannot be done in the government sector. A good example is diabetes. The state does not give free tests for HbA1c, glycosylated hemoglobin, basic test to check the blood glucose, average blood glucose, because that's costly. So there are direct costs and there are indirect costs. This is again important because transport costs have gone up. So each time a patient comes to the hospital, they have to sometimes take a three-wheeler or take the bus. And you can imagine when they come there and there's trade union action in the hospital, right? 2,000, 3,000 rupees, they come to get their medicines. So there are indirect costs. In addition, you lose your earnings, and when you're ill, you're not productive, right? So we have a crisis, and when it comes to illness, we are having another major issue because of the costs and lack of carers. And the third one is from my PhD actually. We looked at how illness will drive people into poverty. Right? To be brief, I will just tell you that poorer people are more likely to be ill, and when there is increased cost of care, they are unable to cope, and when they are unable to cope, they become poor. So illness can be a cause for worsening of poverty or pushing people into poverty. So unless the social care system cushions them, we will be driving people into poverty because of illness. And we know that more and more people are elderly, more and more chronic diseases, more and more obesity, alcohol, tobacco. So we are getting an epidemic of chronic diseases, and unless we support, we are pushing them into poverty. And transport costs, private sector help, all these worsen this move towards poverty, and certain things cushion it. And you will see the most important factor which cushions us in Sri Lanka is the fact that public sector provides free health. So when people compare and say Sri Lanka is not doing well, we are not being paid adequately compared to some other country, that's wrong. Because in those countries you are paid more, but you pay for your health, you pay for your education. Right? You can't just select your parameter and then compare. We were comparing to Bangladesh a few months ago. My colleagues here, we were very happy that Bangladesh helped us. So when Bangladesh was doing well, we were saying, oh, Bangladesh is doing this, that and the other. We are useless. Now Bangladesh is in crisis. And those who compared Sri Lanka to Bangladesh are now silent. You can't compare it. Right? You can't just compare your parameters. So free health is cushioning us. And this is the whole framework which puts everything together. So illness is a major issue which will push people to poverty, and unless we supplement this free health with good social support, we will still be pushing people into poverty. So what's the response to this crisis from an overall point of view? The politicians will say it's economic development, and the economists will say economic development. And some would say not only economic development, you have to spread your what you have benefited, equity. And in addition, others will say, no, we have to develop, there has to be social development, more emphasis on prevention and promotion, all that is good. But from our workshop point of view, I think we have to look at how social support can help us in this crisis. So my argument is that we are facing a huge crisis. It is affecting the health sector. One important intervention would be through the social support. Now, how do we do that? We can think of various ways, but I think the low-hanging fruit is to link the services sector to the health sector. Because in our health system, people are not thinking about accessing the social services. We don't have social workers in all the hospitals. We have a few in psychiatry, in stroke centers and so on. But it is not a system-wide thing. The health professionals, the doctors, nurses, are not aware of some of the social support people can access. The patients are not aware of what to access and how to access. Patients are, when they are sent with a letter to the Grama Sevaka, they have to walk to different places, and see, transport costs are there. They are looking after another person who is ill in hospital. You are trying to struggle and survive. Now you are supposed to go take a piece of paper and go to the Grama Sevaka and try to get your work done. So there is the gap between the social services and the health system has to be bridged. So I'm asking 4 questions. Can we place social workers in healthcare institutions? What are the problems we will face? And how can we solve them? That's the first one. Second one, how can social workers partner with healthcare workers? How will the social workers link with the healthcare workers? Third is, how can social workers help patients in healthcare institutions? The fourth one is more of a policy. That is, what are the steps to in this process? I must tell you, we've been trying to do this for the past 12 to 15 years. We have had meetings with the social services, we have had meetings at the Ministry of Health, we have developed position papers, concept papers, discussed, but the last bit is not moving. So I'm pleading with you, from the social workers' point of view, you all have to push. You also must push that you want to be deployed and work closely with the health sector. Because if we do that at a system-wide, there will be a change. We'll be able to help in this crisis. And when I was invited, I took this up because I think it's important that the social services sector gets ready with this. We are having elections in September. New government, whoever comes does not matter to us. We get a new government. New government during the first year, that's the window where you can push new policies. We can push new policy. That the new Minister of Health, whoever, whichever part. If we push at the correct time, we can make it. The administrative work and things have been done, so the background is there. We need that last push. So my suggestion is that we work in groups. Each group takes one. I think then you can spend more time. See, just one topic. Group one can take the first topic. Group 2 takes the second topic. Group 3 takes the third topic. Group 4 we can leave. We can do that later. I will show a slide. I have worked out some of these my own way, but I won't contaminate you. We will do it as group work, and then I will also share my ideas. Is that okay by the organization? Thank you. Thank you very much.
Now it's time for 5 to 12. It's a lunch break. So we have the lunch break starting 12:45. It's 12. So if we give each group to 20 minutes to discuss the one question, that would be enough, I guess. Yeah, before lunch, I think it's better. More the easiest. So now, who is going to take, I think, any volunteer to take questions, or do you want me to go by the order? Okay, then take 1, 2, 3, 4 for everybody. 4 for everybody, okay? Right, now shall we start the group discussion? I'm also visiting and this time.
I will just show you the next slide, because this is the sort of background work which has been done. So when we talk of placing, that's group 1. Group 1 is which group? Alright. Hi. So first question is, should we be placing social workers in hospitals and clinics? Start with, you can think of the hospitals first. What are the problems you are likely to face, and how do we solve them? Pay, designation, who will pay you, because you are in a different place now, right? You understand, these are, and do you require special training to be in these places? Yeah. So you all have to discuss those, right? And think of possible, you'll have to have certain things which can be done low cost, almost immediately, plus the ideal. You can think of health social workers, medical social workers, what happens in NHS in UK. That's far, far away. You won't get that in October 2024. Right? So that's why. What we discussed with the Ministry of Health and the Social Services Department is for social workers who are paid by the Ministry of Social Services. They are sent to the hospital, and you have a hospital desk or an office every day or certain days of the week, and they are paid by the social services. Because if you try to develop a new cadre, you have to go to Treasury. You won't get it. If you're going to shift new cadre to the Ministry of Health, you won't get it. Trade unions are going to protest. Right? So you have to think of practical things for Sri Lanka. The second one is, how are you going to partner? So is it a visit or is it a desk? Who is the lead person? What about the AR and administrative and ARFR, the whole list of things which you have to sort out, right? So that sort of area. Yeah, sure. Yeah, you see, this is, I've worked on this area a bit because this is what we have now. So a patient has got a stroke and is in hospital. He wants support. That patient has to go to the office and find the place and access. But what we are saying is, can't we get a social worker to come here to the hospital? Part-time, full-time, visiting, whatever. But system-wise, see, when we talk about this, suddenly the neurologists say, we are doing it in stroke units. That's not the idea. The idea is system-wise. Link up the two systems, right? And then, because that helps the social worker here to link up. So patient is from, and we have free access. Another unique thing in our Sri Lankan health system, if you go to Mullaitivu tomorrow and you want to enter hospital, no questions asked. You are in Mullaitivu hospital. You go to Hambantota hospital, the next day you will be treated just like any other Sri Lankan. There is no, so the social worker there should be able to connect and say, you have these things you can get, these are the things you can get, these are the places. And if the communication network, nowadays communication is improving, like Visa Online, things will improve. So then you'll be able to tell this person to go and meet such and such a person in the office. You see, we don't realize how helpful that is. You don't realize how helpful. How many calls do I get asking which doctor to go and see, where to go for the tests? I would have been asked 100,000 times. I provide that information, but that information should be available. So this is a worse scenario because these patients are really, some of them are really poor. They don't have access. They don't know anything when they come to hospital. So that's what I meant by, then how do we partner with healthcare workers? Again, we thought through quite a lot in these discussions. To have a desk or office which is loaned by the hospital, right? Always become important administratively. The first question they ask is, who is going to supervise the social worker? Hospital will want to know who is going to supervise. Keep the supervision with the Ministry of Social Services. Don't try to mix. Just ask for a desk, an office. We should develop a printed form. There should be someone who refers. So you say, right, these are the criteria. Only consultants, specialists are able to refer a person for social support. Later on it can develop. Initially keep it at that level. Right? We get to the level of actually drafting a referral paper. Right? So you keep the original with the patient and one goes to the is kept in the ward, one is given to the patient. Social worker is in the office. The patient goes and meets, or the carer goes and meets the social worker, who is now in the office in the hospital, who refers with the appropriate place. So that's the framework we thought would work. How can they partner? How can they? But this is almost the same because this is the sort of form we developed. Right? So you have certain basic data, and the consultant like filling the medical certificate. We did it in a similar fashion to the medical certificates which doctors fill. So that it's not very unfamiliar. You just get the house officer will fill most of it, and the consultant will certify it. And this is also important, so that you have some sort of screening, and then it's referred, and the social worker takes over. And that part you all will be the experts. And when it comes to implementation, also we looked at it. That's group 4. A lot of work has to be done because this is something which we are discussing now. You have to get approval by 2 different ministries. So secretaries have to agree. You have to make sure there are no conflicts about designation, right? Because one category will say we don't want to speak to the other category. Right? Most people don't, but there can be. Most people are not worried actually nowadays. You have to get all these approvals. And now there's a bit of a complication because teaching hospitals are with the ministry, other hospitals are with the provinces, and social work also is a provincial, devolved subject. You have to think of human resource development, and that's where the institute comes in. That's where assistance from overseas collaborators come in. And then we have to educate the public. This is what we have to do. If you have a problem, this is the number. And now you would have noticed that we have very good, these emergency numbers. For example, distress, there's one number which is 24/7 working at the National Mental Health Institute. And all the patients who are discharged from there have that number. So they have prevented several suicides. People have been walking along the rail track to commit suicide. Last moment they use the number. So like that, we have to think of a program way to get this across to the people. So those are some of the. So group 1, 2, 3. Yeah. Thank you.
තිබ්බද අට 8:30 ද පටන්?
8:30 පටන් ගත්තා. මම පරක්කු වෙලා ආවේ 9 10 o'clock වගේ ආවේ. ඒ
Wi-Fi තියෙනවනේ මේ ඉන්න ගන්න.
ඔව් නෑ නෑ මෙයාගේ ෆෝන් එකකින් ගත්තේ. ෆෝන් එකෙන් wifi එනවා. කොඩි තෝස්කේ
එයාගෙන මෙහි හොටෙල් එකේ ගත්තේ.
නෑ නේ හම්බුනේ. ඔයාට හම්බුණාද? හම්බුණාද?
මේ
කනෙක්ට් වෙනවද?
පාස්වර්ඩ් එක.
ඒකයි.
මේ හොටෙල් එකේ තියෙන Wi-Fi. ඔයා ගත්තේ නේද?
ඉපත් කරනකොට මේව කරමු. ඔෆ් කරන්න දෙන්න. ලයිව් එක. wifi item start කරනවා. මේ ඔෆ් කරොත් කරදරයි. ආයි ලයිව් එක පටන් ගන්න එනවා. කරදරයි. කොහොමද තිබිච්චාවිද?
නෑ නෑ. මේ free Wi-Fi දුන්නේ ගත්තේ හොටෙල් එකේ තියෙනවා. හොටෙල් එකේ තියෙනවා. අර කොන්නගේ ඉල්ලගන්න.
Hello, my dear friend.
හවස තමයි කාලේ.
මම නම් ලන්ච් එකෙන් පස්සේ යනවා.
නෑ. ස්ටඩි කරනවා. ස්ටඩි කරනවා.
මං ස්ටඩි කරන්නේ මං දැන් වර්ක් කරන ජොබ් එක කරන්නේ ජොබ් එකක්.
වෙන ජොබ් එකක් කරනවා.
ඔව් මං ජොබ් එකක් කරනවා ඩේටා ඇනලිස්ට් කෙනෙක් විදියට. ඔව්. Mama 2000. 2000 January 30.
IT job
Oh, IT side එකේ තමයි ජොබ් එක කරන්නේ. ඒ ඩෑෂ්බෝඩ්ස් වගේ හදන ඒවා තියෙනවා කියලා. ඒ වගේ කරන්නේ.
First and the second. Okay, so we are going to start the group discussions, the main session discussions now. Shall we prepare with your presentations?
So we got the first question. Should we place social workers in healthcare institutions? What are the problems we will face and how we can solve them? Pay designation, full-time versus part-time training. So yes, we can place social workers in healthcare institutions because it is highly beneficial. So they play a crucial role in addressing the psychosocial needs of patients, improving patient outcomes, and reducing the burden of medical staff by handling complex and social emotional issues. So let's talk about what are the problems we will face and solution for integrating social workers into healthcare institutions. So first one is designation and role clarity. So unclear job titles and roles can create confusion about the social workers' responsibility within the healthcare teams. So for the solutions, we can clearly define the roles and titles such as medical social workers, healthcare social workers, clinical social workers. So ensure those roles are outlined in job descriptions. So, and as for the job scope, it includes specific responsibilities such as discharge planning, patient counseling, and community resource coordinating. Conduct role orientation sessions to educate healthcare staff about the social workers combinations. So the second problem is full employment state, that means full-time or the part-time. So determine whether the employee social workers on a full-time or part-time basis can impact social service qualities and availability. So we can implement full-time for the preferred in larger institutions like hospitals where patient need as concert and allowing ongoing support and relationship building. So as for the part-time, is suitable for smaller facilities like specialized unit where demand fluctuation is flexible schedule to attractive qualified professional while managing costs. And also we can use hybrid models, employment combination of full-time and part-time social worker based on department need such as critical care or outpatient care. So the third problem is pay and compensation. So comparative salaries are necessary to attract and retain skilled social workers, but budget constraints in healthcare institutions can be a challenge. So as for the solutions, we can give comparative salaries. That means benchmark against industry standard to medical social workers, consider pay scales that reflect experience, qualification and responsibilities. And also additional benefit can be given by the offering attractive packages, healthcare insurance, allowance, and also including health benefit, professional development opportunities, and support for license renewable. So I will invite Amra Saya to continue the presentation.
Okay, let's move on about related to the training concept, how we connect the social workers in the healthcare institutions. Before that, I will give an example. I was worked in the internship at Sri Lanka, that's an IT company. They are developed a concept. After the A level, they are intaking a 6-month module training, and after that they are giving a 6-month job and including a 1 year. After that they are offering our 6 years contract. That means they are giving a scholarship for us. They are paying for the degree, and they are giving 3 years job. Like that, they are, because they are giving the training and the on-job training and everything, they are developing workers with their what the company need. That like that the HCL, what are the procedures they are having, what are the process they are doing. They are creating their workers theirs own self, because some education systems are different. There's that company's concept. Like that, we are also trying to develop a training module. What the health institutions needed as a social workers, how can we combine with the health institutions? And also, we already mentioned we have some names: the medical social worker, healthcare social worker, clinical social worker, and some others have a psychological social worker, and so many cycle. We already combined work with our health institutes also. Based on that, now we are in our modern digital world. If we are doing a digital world, we are trying to initiate a digitalization. All the we can work with remotely also, because the full time the hospital is working 24/7, 24 hours working the whole days. Based on that, we can't work as a 2 or 3 clinical social worker or someone whole day. Like that, we are connecting our remotely. We can connect with those people who only need. Like I got the example, Shanti Markam organization, there's a hotline numbers, and there's some Parway app that's introduced last week. There's a new app. If they are new to any counseling and consultation, any you need to share your issues and find any your opinions or ideas, you can share with remotely or the phone or through the apps. Like that, if you need any, we can connect with, like example, one client you need to meet, but you are not available at the moment, they can connect with the remotely, and they can get their opinions, what are these, we can give some counseling sessions and those things. Like that, we can connect with them. These are the our training modules and those things. And also we can the integration into the healthcare team. We can get their other hospital staffs as well, like nurses and some, and the staffs who are in administration. Those things we can get their intake, and we can give the trainings for those team also. Then we can get those care team supports as well. Founding the resource and allocations, because we have lack of resources, we need to prioritize our needs and needs. Based on that, we need to identify what are the resources we have. Based on what are the resolve the issues and problems. Based on that, we are doing some interventions related to that, and we will find out the resources and how can we manage those lack of resources based on our trainings. Thank you.
So thank you very much. I think that was very interesting and very comprehensive. Of course, we should also, for practical purposes, we must also think of not having a new designation, because the moment you want to have a new designation, it has to go to the Cadre Commission, it has to be approved by the Treasury, and you have to go and justify with the Treasury that you are producing a new category. And then you have to place this new category according to the administrative circulars and look at the salary structure. If you make it that, you won't go there. So I think that can be the next stage when it develops. When we first, I think the important thing is to get the social workers into the health sector. Later on, phase 2 is where you start having medical social workers or healthcare social workers or whoever, specially trained, special degree courses and a professional development. So please think of that other category also. Thank you.
Just to add into that, sir, so we are now actually getting social work undergraduates to the setup where I work. So I used to get social work students to work with me during their training period. So where the NIST has started sending over about more than 12 years, they are sending students for me to do casework and group work. So that's where you can informally start giving the opportunity for the student social work to embark in this field, and gradually they can, when they pursue their higher education, maybe postgraduate even, they can join, and they can itself think of what are the areas that they can develop and link up with the healthcare sector. So shall we, move on to the next question.
So good morning, doctor and everyone. I think this is a good opportunity for me also to address this issue. Sir wanted to understand about how can a social worker help the patient in healthcare institution. I am a professional social worker before 10 years back. I specialize in counseling and currently working as a psychologist in private sector. I have many barriers. If I address this forum is big, not enough. So we were discussing how we can accommodate a social worker in the school hospital setting. Ms. Rasika also started to tell we were getting a lot of intern students in hospital, but they after the program they leave the hospital. So we, as a criteria, we would suggest at least one social worker can accommodate in the hospital. In future, we can think about each and every department, like each and every ward, they can accommodate one. And also in our system, professional program, we have elective subjects like counseling, poverty alleviation, psychiatry, social work, like that. So we are getting specialized areas also. So we believe there is no barrier a social worker can support the patients. And also in our educator role we can play. Then also we can play many roles as a social worker. Now currently I'm working with some community medicine doctors. They always tell we give a lot of medicine but it's not working. Ahmad, you just call them and see what made them this problem. So community medicine people always welcome social workers and counselors to join hands with them, and that would be a productive management, I believe. So in our idea criteria like that, and refer this educator part, we believe that awareness on each and every community non-communicable diseases, sometimes these people who doesn't want to reveal their health problems, so they go for different traditional medicine method. So we as social workers, we can get joined together with the Gramani Ladari or any other MOH system. We can go and educate the patient or the public. We have this kind of facilities in the hospital. Why don't you go and take medication and all? So like that. So there are a lot of awareness program we can do. If the system included us, I believe our professional knowledge would support the country. Why don't you join the network?
Thank you, Stika. According to our discussion, we discussed the prevailing situation in Sri Lanka. Within our discussion, we identified need of having that the intercollaborative practice in health sector, especially within the classroom. We are teaching that as a practice method of social work intercollaborative practice. The ways and means to apply with the intercollaborative practice, but the health sector is the very required and needed place that having the intercollaborative practice. It means that the collaborating with that the each professionals aiming that the each cases. So our suggestion is that in Sri Lanka scenario, that in the academic programs, especially in NIST, we are teaching that kind of methods, but the applicability is that is not happen in a proper manner. So we are suggesting to having that kind of mechanisms, as well as we, as a social worker, we can contribute to betterment of the patient, that having in the inclusion of the patients according to the Sri Lanka scenario. Some of the, especially as an example, that the mentally ill people, there are so many that kind of patients in the society, but they are not network in that the service providing sector, especially that the hospital setting. So social worker can contribute them to include that kind of services in the country. So I invite Ms.
Thank you very much. I'm going to talk on the social stigma in the society. It's a big issue in our society. Because of the social stigma, normally the patients, some illnesses like AIDS and cancer, and even the people who are having diabetes, they don't like to reveal that they are having that so-called illness. So because of that reason, they are not taking medicine. So as the social workers, I think we have to promote them to go to the doctors, particular consultants to meet and taking medicine. So because of that reason, I think social worker should be there, and that networking also should be there. And regarding this lobby, demand of social workers, and the social worker has to do the lobbying part also. And at the same time, empowering the patients also, social worker can do. Because of that reasons, I think there's social worker has to do a role of advocate also, to make awareness of available resources, because resources are there and our clients are there. So we have to link those resources with the clients. So because of that reason, I think social workers' role is very prominent and imminent. So my colleague will talk on the rest of the others.
To address these attitudes of the professional is a big barrier for all the problem. One of my colleague who is belong to community medicine, he was asking who is biggest resistant for your profession. I was thinking resistant, they talk resistant, who? Psychiatrists. Like that he was kidding. No sir, what I want to tell, lot of years, many years people take medicine. Finally, they also don't know why they are taking medicine, what caused them to go for this psychiatric medication and all. Then once we take all the records and check, this is a history because of a divorce, last 10 years taking medicine. If we could attend the divorce part properly before 10 years, I don't know whether I'm correct or wrong. Like that, many simple domestic violence, maybe a behavior issue, maybe an ADHD issue, sending them to medication, finally they will end up in conduct problem, many other psychology issues. So professionals, all the professionals are equally treated, equally seen by all the other profession. So we should respect the profession. I hope social work is not a barrier to any profession. I was guiding my juniors, don't worry, after 10 years you will be end up in a professional place. So we have very motivated way of encouraging people. Also we also motivated from our senior social workers. We believe we can do a lot of works as a team, sir.
Can I add something? I think as a social worker, we want to research about what is going on there. So as a patient, maybe patient rights and everything, we should include this thing. And the other thing, we have a role in the education part. I think maybe other sector, we have what is the mental health, what is the illness and other things, because of all are concerned about the illness. But in our team, we concerned about the part of mental health. So everyone have a mental health. So other thing, as a social worker, rehabilitation part also one of part in there. So when we have a client, he have a lot of barriers. So we can recover the treated in hospital, doctors describe the drugs and other thing. we have to rehabilitate them the client. So that's the one thing we can to add. Thank you.
Thank you very much. I think the one important point you made was about linking with the community. So we have a very extensive MOH system. You all know that started in 1926 for the benefit of the overseas experts here. From there on, we have a preventive sector which is with a MOH. And MOH is in charge of a population of people. And so that's one place where social workers can be linked. And the Ministry of Health is starting a new primary care system in the country. So that would be also like the MOH, the preventive sector. So that will be another area where you can get, you can link up with. I am a bit concerned with this term client. You know, I think it is used, the term client, but immediately when you use client, you are bringing in business. And I am a bit uncomfortable. I am uncomfortable because Sri Lanka, we are not using this term client. It could be a person or another human being. Think of it. Not beneficiary, you can think of a neutral word. I mean, think of a word which doesn't really stigmatize, just a person is a person. Now we are talking of person-centered healthcare also, which shifts. Yeah, in the hospitals they use patients, which is not very good. That's another label. But Sevala. Yeah, but think of it. You know, these words get loaded, and after some time they become.
No, I don't want to take this much, but so we always say that we work for humans and human well-being. So to work with everyone's well-being, we can call it as we work for humans, the person's content. So it's person-centralized care. Whatever the care we provide, socially, medically, psychology, it's ultimately end up with the person-centered care. So I think it's the best word to use the person who you are. So I think it's something to think for everyone. Okay, right. So shall we go with the third question?
Good afternoon to all of you. So our team, we basically discuss, we try to make an attempt to answer the question. It's on how can social workers partner with healthcare workers. So basically in our team, we try to make an attempt to identify from grassroots level and also from kind of an institution level also. So first thing that we discuss is shift basis, that is called JMO model. So it is basically link healthcare workers to healthcare workers and social workers. So one of our team members is going to describe that to you.
I am also a social worker. I am experienced as a mediator. So I he have done many things. Here this there's a basis by shift basis. Now the good model is judicial medical officer versus in-house doctor. See how the judicial medical officer is seated in separate area, in judicial division, judicial office, and the in-house doctor only treating the patients in the hospital. Now it is referred by a printed form, checklist. With that, immediately the JMO come and examine and go. So similarly, the specialist is JMO who advise more to the in-house doctor. There's a fracture, you have to treat the patient like this. So there is a link. Similarly, the simple is simple printed form. No need a big tedious form, because paperwork will be more paperwork. We have to reduce the paperwork. So that is a simple checklist. The social worker will come. On the shift basis, he is available in his department because he should be access to all the wards, not to the just